Ladies and gentlemen, please welcome to the stage the Solutions to Address Health Disparities panel.
Okay. Well, welcome everyone. Hello, I'm Squires, and I'm President and CEO of Americares. And at Americares, we believe that everybody should have access to health because health is essential for everything else. And never has that been more clear than in the past 18 months with this COVID-19 pandemic, where health disparities have been exacerbated everywhere. So we have to think about this for a moment. Millions of people around the world simply do not have access to health, and this prevents them from getting quality care. That's why today's discussion is so important. At Americares, we work in partnership. And at Americares, we are focused on removing barriers. We remove barriers in getting medicines, remove barriers in getting good quality care in chronic and infectious disease, and in mental health. And we do this every single day and in emergency settings. We work to ensure that local health centers and people in the surrounding communities can get the care they need so they can thrive with better health. And we do this with long-standing, trusted partnerships in underserved communities around the world. So to get in this discussion a bit further, I'm so thrilled that we have our panelists with us today who are going to talk about some of the causes and the locally led approaches in addressing health disparities. So let's get started. Okay, so I'm going to start with Toyin Saraki, who is a Nigerian leader, philanthropist, and advocate for maternal, newborn, and child health, as well as a champion for socioeconomic empowerment. As the founder and president of the Wellbeing Foundation Africa, she works to improve health outcomes through education, advocacy, and empowering community health workers and midwives. Welcome, Toyin. Thank you so much for joining us.
Thank you so much, Christine. It's actually a pleasure to join you in Americares and all the other speakers today.
Thank you. So our next panelist, Angel Ortiz Ricard, is Senior Public Health Advisor at the CDC. He currently serves as the Vaccine Equity Coordinator for the CDC's national response to COVID-19. Angel has 20 years of experience in public health and disease prevention and has dedicated most of his professional life to working on behalf of HIV-infected and affected communities. Welcome, Angel. Thank you for joining us.
Thank you for having me here. It's a pleasure to share this panel with panelists.
Thank you. And for our next panelist, someone I know very well, is Dr. Rashad Massoud. He is Chief Program Officer at Americares. And Rashad has more than 20 years of experience in global health. And at Americares, he oversees our health programs for people affected by poverty and disaster. And I want to add that Rashad has worked in quality improvement, directing initiatives that have strengthened health systems around the world and in marginalized communities. So Rashad, it's nice to be with you here today in person.
Thank you. It's wonderful to be with you.
Okay. So we're going to get into our discussion and set us up a little bit. Health disparities by race, gender, or ethnicity are the result of inequity, too often bias, discrimination, and the conditions in which we live and work have a profound impact on health outcomes. So Toyin, my first question is for you. So globally, we see that women remain largely excluded from decision-making, including in decisions in health. Women comprise roughly 70% of the global health force and perform the majority of the sector's most difficult and dangerous jobs, yet they only hold about 25% of leadership positions in the health sector. And women are often left out and excluded from policymaking discussions and decisions. So Toyin, what do you see as the impact of this underrepresentation in the health sector here and the impact on women?
Thank you so much, Christine. Your question is absolutely pertinent and it's very important to address, not just because I'm a global health advocate and a woman, and not just because the calls for equity and equality in health have risen from murmurs to bellows, but because at the Wellbeing Foundation Africa, we actually put the woman and her child and her family at the center of all our programs within her community, and we need to reach her. You've rightly stated that women represent 70% of the 43 million workers in the global healthcare industry, yet we occupy only 5% of the leadership positions. 90% of registered nurses globally are women, and women remain the backbone of the informal workforce of unpaid caregivers, of sick relatives, community members, and children at home. Yet our contribution doesn't receive its true recognition, and our efforts are yet to translate fully to representation of policy and decision-making tables. We've got to be honest about ourselves and honest about the system if we're going to bring about the required change in how the global health system sees us, treats us, and appreciates us. And this must be done, as you've rightly identified, by highlighting the barriers that female healthcare workers face. When it comes to female leadership of the health workforce around the world, the most targeted and tangible excluded from leadership grouping are the female health workers, and typically midwives and nurses, the caring professions. Culturally, in Nigeria, where I come from, we have regions where families prefer, because of their culture or their religion, women to be treated by female medical workers. Yet these are the same regions that are overrepresented, high burden as out-of-school children, which creates a human resource supply problem that denies vulnerable women and girls access to professional medical services. Now, in 2016, we've got the evidence. The Midwives' Voices, Midwives' Realities report found that the barriers to leadership largely lie in the social, professional, and economic perspective, the very same social determinants that actually affect giving care to the patient, from gender inequality, physical and sexual violence, lack of safety and security, being disrespected for being single, unmarried, and working, not being empowered through training, or even if you're empowered through training, you're unable to provide quality care, low and irregular salaries, lack of support for housing and transport, too little or delayed leaves, being rendered absent from policy dialogues, being unable to contribute to decisions, restrictions on practice, inadequate bonding, a lack of supplies and equipment, and all these contribute to the manifestation of moral distress, burnout, and departure from the profession in an era where the world needs more midwives and more nurses, particularly to even combat the COVID pandemic and to keep routine services going while the tertiary facilities are dealing with COVID. So these barriers go as far as undermining our well-being and our livelihoods. They create broader gender equality gaps and have a very adverse effect on the global health systems overall. From the social context, the occupational segregation is still vast. 24 million of the 28.5 million nurses and midwives globally are women, yet men, on the other hand, are more likely to be physicians and specialists than women. So these ingrained gender stereotypes have constrained men, actually, to see nursing as purely women's work, and societal norms that we have to dispel continue this archaic notion that single, unmarried, and working women are not worthy of respect, creating a culture that increases our lack of security and safety. So, but when we look at the other side of putting women at the heart of delivering healthcare, I have seen at the Wellbeing Foundation that even though I have exceeded the 35% of the leadership roles of the global healthcare industry as identified by the World Economic Forum, I have seen clear impact that training women and remunerating them properly and putting them at the heart of policy dialogue, high-level decision-making, brings almost instant impact to the quality and the coverage of our programs. I'm a solutions person. The answers aren't hidden. We're at the time where impactful and far-reaching global commitments are being fostered across various spheres and all the intersectional issues. The WHO and the Women in Global Health's Gender Equal Healthcare and Workforce Initiative has shown that the groundswell of action and ideas and commitment will actually improve gender equality in the healthcare workforce. I had the courage to give women leadership when I became the inaugural global ambassador for the ICM. I moved my advocacy and action by deliberately engaging 45 midwives at the WBFA as a community health workforce to take our programmatic actions and advocacy to communities. And now I look back only with joy at the power of professional autonomy that they have demonstrated. They're now the backbone, heart, eyes, hands, voices, and the community leaders of the Wellbeing Foundation. Our impact is clear. Since I engaged them, we went from possibly reaching 60 or 70 women a month only in emergency to routinely caring for and counseling no less than 8,000 women each month. And we have not lost a single woman to death during or after delivery.
That is
The way
amazing.
forward has been posted.
Thank you. Thank you so much. And thank you for laying out the barriers and the potential solutions. And we'll come back to that in a little bit. Angel, question for you. So the United States has been able to rapidly establish, we're going to talk about barriers here, access to the COVID-19 vaccine for all of its eligible population, yet we've been unable to reach our goal of herd immunity, and this has caused preventable deaths. To what do the CDC, it's a big question, so I'll narrow it a little bit, attribute to these challenges? And what are the barriers preventing communities from getting vaccinated, and what is the role of trust?
Well, we know that some racial and ethnic minority groups are being disproportionately affected by COVID-19, and there are factors that may contribute to increased risk of getting sick and dying from COVID. Among these factors, we can include discrimination, healthcare access and use, occupation, educational income gaps, and housing. And CDC has been working in trying to remove those barriers. And, I'm sorry, this is a subject that we can spend hours talking about it. So I'm going to go straight to, it is important to consider factors that influence access to quality medical care during COVID-19. Inadequate health insurance coverage is a major barrier to medical care. Unequal distribution of coverage directly affects health disparities, as well as unreliable transportation also plays an integral role in persons having difficulty accessing health care. Lack of transportation leads patients to miss medical appointments and potentially interrupt their ability to get refill or their medications. Also, the use of stigmatizing language in medical practices and limited access to culturally appropriate resources are other barriers that can contribute to reduced access to medical care. It is critical that all communities have access to medical resources, including culturally and linguistically appropriate resources. So those are the biggest barriers that we're dealing with. But CDC strives to remain culturally aware of all racial and ethnic minority groups, especially those at higher risk for illness or death from COVID. And the agency accomplishes this by recognizing historical trauma to help provide context to present-day decision-making, continuously developing culturally competent and relevant messaging, and addressing the ongoing impact of medical professionals on communities of color. There are two contributing factors at the forefront, and they are around racism and historical events involving medical distrust. And when you have patients that don't trust the system, that don't trust their doctors, that don't trust medicine, there is a big problem.
Thank you.
Health and vaccine equity are essential parts of CDC's mission, and CDC works with national, state, tribal, territorial, local, and community partners to promote COVID-19 vaccination among Black or African American people and Hispanic or Latino people. And to support this partnership, CDC has provided funding for organizations that works directly with racial and ethnic minority groups, such as health departments and community-based organizations. They provided funding also to health department across United States and the territories to work in collaboration with community partners to support efforts to address health disparities. Also, we've been providing funding to community health worker services to support COVID-19 prevention and control, and training and technical assistance and evaluation for these workers. Additionally, CDC efforts toward increasing vaccination coverage across different racial and ethnic adult populations currently experiencing disparities and reaching vaccine equity for racial and ethnic minority groups include funding for a national organization serving racial and ethnic minority groups, 4 medical organizations serving also racial and ethnic minority groups, and 34 jurisdictions to work specifically in reducing health disparities. Also, we funded some foundations that works in collaboration with the in partnership with the CDC to try to reduce as much as possible health disparities. And through these other partnerships, CDC is working to remove barriers to COVID-19 vaccination access and promote vaccine equity. In line with this effort, CDC is also working with the Federal Retail Pharmacy Program to conduct community-based activities and use data to ensure COVID-19 vaccines are accessible in all communities. So it's a lot of training, technical assistance, and a lot of funding that CDC is putting out to promote vaccine equity and reduce health disparities.
Thank you.
There are two websites that I would like to share with you. It's the Vaccine Equity for Racial and Ethnic Minority Groups webpage and the Health Equity Action webpage if you want to learn more about these efforts.
Thank you so much. And I'm going to ask Rashad to jump in here. So based on the insights that Angel shared, can you speak to how working alongside trusted messengers, a thread here, trust, right? How can that make an impact? You've seen this work globally at Americares and other health organizations. Can you share a specific example, Rashad?
Absolutely. The example that comes to mind right away is the one that we're working on today with CDC. We're very privileged to be working on the CDC Vaccinate with Confidence project, where we're aiming to, with the safety net, promote the vaccine uptake amongst health workers and ultimately so that they would be the influencers for their patients. Multiple studies have shown that people trust more than anybody when it comes to something like the vaccine uptake, the doctors and nurses that see them for their regular conditions. And so through working with the health workers, we're able to create that chain where they themselves get vaccinated and influence their patients to do so. In this work, we just completed a study where we were able to demonstrate that if a health worker feels that they know enough about the vaccine, they are 10 times more likely to get vaccinated themselves and 4 times more likely to recommend the vaccine to their patients. That's huge. That would make a very big difference in the situation that we have today. When I reflect on globally, the example that comes to my mind is early work in maternal health, where trying to get young women to access antenatal care, to access skilled delivery. Working with the young women was not as successful as when we understood who the influencers are for those women. And guess who it is? It's not even the husbands, it's the mothers-in-law that are the influencers. So can you imagine convening workshops with mothers-in-law not because of them, but in order to get them to influence their daughters-in-law to come and access the care? That's the type of power of influencers, trusted messengers that we are working with. And again, it's a real privilege for us to be able to do this and to have an impact through this effort.
Thank you. So we could discuss this for a very long time, and I'm hoping we're going to have a follow-up at maybe another Concordia event, but I just wanted to wrap us up very, very quickly here. And to summarize what I've been hearing here is what's really important is understanding the barriers, and thank you for walking us through those barriers, and locally led solutions, empowering the community, and trust. Building trust is essential with patients, providers, within communities, with any organization, NGO, CDC, and any foundation that's working with these communities. So really, really appreciate this discussion. And if we continue to work this way and build trust, we will achieve health equity and better health for all. Thank you so much to our panelists for joining us today, your incredible insights and experience, and thank you to the audience for watching us. Appreciate it.
Thank you.
Thank you.